Really outstanding talks. We're going to wait for some questions to come in. We pushed back lunch a little bit to 11:15. We'll have a little bit of a shortened Q&A session. So I apologize if we can't get to everyone's questions, but I encourage people to put them in. While we wait for those, I think part of our job is supposed to be for CME to kind of summarize some of the key points. I think there's so many good points here, but when we have IBD and pregnancy, to me, a few key things that came out that all three people talked about. Let's, make sure we're taking care of mom. Healthier mom is healthier baby. That has to do with what medications you give them, what their nutrition status is. So let's make sure that that's a big focus for these patients when we're taking care of them. A lot of medications we can give during pregnancy are considered relatively safe or very safe. There are a few that are not. And then, let's not forget to address the nutritional aspects as well. Make sure iron and especially folic acid and these things are well supplemented. And I had never even thought about like the zinc and calcium or vitamin C for healing, but I love that point. So, all right. Anybody still no questions? I'll start with a quick question then. And this is probably, I'm an IBD person, so maybe a lot of people won't care about this. But for Siobhan and also for Dr. Johnson, Dr. Proksell, Dr. Johnson, excuse me. One thing I found interesting was how, the upadacitinib had better, some changes associated with really meaningful doses that we would give, whereas the tofacitinib required really high doses. So if you had someone who you're in a worst case scenario and had been doing like really well on, for example, like upadacitinib, and you stop it and they don't do very well. And so let's say you're out of the first trimester and you really think they need to be back on a JAK. Would you switch them then at that point to tofacitinib because of that dosing discrepancy?
I wouldn't. If they're out of the first trimester and they're out of organogenesis, I would have a discussion with them about getting started on upadacitinib again. Because really, I think that the biggest risk is in the first trimester of having those complications. It's obviously incredibly nuanced, but you don't know that your patients are going to respond to tofacitinib. There's data to show that UPA is more effective. You may even not have that as an option depending on what their actual disease is. And so I think it would be a joint discussion between us, obviously, the patient as well, but I would be pretty willing to restart UPA if that was the right thing for the patient at that point. How do you feel about that?
I agree.
Awesome.
I honestly feel like usually I'm not the one managing these medications, but I would agree with all of what you said.
Awesome. Thank you for answering that question that pertains to me when I treat these people, because I know there's not probably a whole lot of other people in our group here. Okay, so we do have some questions coming in. This one is probably best for Dr. Proksell and Dr. Johnson. How often do you monitor fecal calprotectin during pregnancy? I know Dr. Johnson, you said you don't necessarily monitor it that closely. So maybe Dr. Proksell, what do you?
I've never monitored it. Like I said, I just had a patient a few months ago who introduced me to it, and I was like, I've never heard of this before. So
it's great. We love it. You should try it.
But her gastroenterologist was monitoring it.
Yeah, I think in an aspirational world, I would like to have a baseline before they're pregnant, and then I would like to check it every trimester. And that's ideal, right? And then you have a really clear idea of what's happening with their disease state during pregnancy. But I think you need to know beforehand if that actually correlates with their disease state as well. In the reality of things, getting patients to submit a stool study 4 times in a year is a little bit rough, but some people are really motivated to do it. And if you can, then that's great. And that's ideal. But I at least like to get it once.
I actually want to ask a question now, because we obviously see these people in pregnancy all the time, but how often do you see your patients once a trimester?
I do.
All right. And then so for ovulatory stimulation in our IBD patients, any additional counseling or considerations that you guys have for any of our panelists?
Do you mean just for like fertility preservation or egg retrieval? I assume that that's what it's getting at.
Or it could even be just for infertility.
Yeah.
Yeah. I'm guessing maybe for infertility, if you're, yeah.
There hasn't been any data from my perspective to show that there's an increased rate of flaring with doing this. And I think any type of reproductive endocrinology assistant that these patients should need is completely fine from an IBD perspective.
Yeah, I haven't seen anything either. So I think that would be fine.
Great. And then we have a question about folic acid if there's small bowel involvement. So it sounds like, the folic acid recommendations were a little different based off of patient characteristics. So can you give a little more feedback on that extra folic acid if there's small bowel involvement?
Yes, so we're looking at kind of where the disease is located and where absorption happens. So if they have like duodenal Crohn's, probably not necessary, but it is absorbed primarily in the distal jejunum. So if they do have jejunal Crohn's, I think it would be necessary to, based on our guidelines, increase your supplementation closer to 4 milligrams of folic acid.
And I think the other thing to think about is if they've had extensive surgical resections and their transit time is faster, they may need extra as well.
Great. And then we have a question about a provider here from a resource poor area. Do we have available, can they refer them to see, sounds like to talk to Stacey or one of our other dietitians if they're out of state for like a telehealth?
I believe they have to be established in our GI clinic to access our dietitians, which is a bummer answer. But I will say there are fantastic IBD dietitians that are available virtually. So if you want to write this down, Romanwell, and they're pretty specialized in IBD and eating disorder overlap. So Romanwell would be a good one. Kim Braley, Brally. She is fantastic. And those would be my top 2 recommendations as far as virtually.
And then can we scroll up a little bit? Because I think that might be a couple different. Okay, so it looks like, how do you manage a patient who has active IBD, who has significant hyperemesis or poor weight gain? Where does the dietary intervention end and you would escalate to medical surgical management?
Okay, so I like to ask what they are able to eat. Pretty much that's where we start. Sometimes it's like, can you drizzle olive oil over your hash browns? And while that's not ideal, that's what we have to do to try to maintain maternal weight. Maybe if they're like, I can't keep anything down at all, we consider smoothies and try to make them really high protein, really high in calories to try to kind of hide that. The taste, I mean. And then as far as medical intervention, I'm going to let the
I
experts
think
handle
that has to be collaborative, right? And so if patients are having hyperemesis, and that's why they're having nausea and vomiting, then that's primarily going to be managed like through their obstetric team. But if they're obstructing, that's a completely different scenario, and no really amount of medical management is going to help that. And if someone's obstructing, I wouldn't hesitate to send them to surgery for an obstruction from a stricture that needs to be managed. And so I think the first question is, what can they tolerate? Like Stacey said, and then the next question is why is this happening? And is medical therapy appropriate, or are we just kind of spinning our wheels, and do they need something more definitive?
I'll also say hyperemesis and nausea and vomiting generally is most common in the first trimester. It peaks at 9 to 10 weeks with the highest level of HCG that patients have, and it usually resolves at the end of the first trimester or early second. So it's not to say not everyone, like some patients do have nausea and vomiting throughout pregnancy, but most don't. So if you're continuing to see symptoms in the second and third trimester, then it's like, well, is there another cause that could be related to the IBD that we could actually treat? Because I think the hyperemesis itself is hopefully going to resolve without too many issues. And like the patient will just be able to get over it and start eating normally again.
All right, for the sake of time, I'm just going to do one more, but I'm going to kind of combine these two. So question about patient in remission on Rinvoq, planning for pregnancy, wants to transition to an IL-23, and kind of along those same lines. When some of our attendees have these questions and they'd like some input on this, can they basically send it to for a second opinion, for example, to see Dr. Proksell at our clinic?
Yeah, I'll answer the easy one first. I'm happy to see any of these patients. I have time set aside in my schedule to do preconception counseling and then to co-manage patients with you during pregnancy. I don't take them. I give them back, but I'm happy to help with any of this. Separately, how do you transition a patient in remission on Rinvoq to an IL-23? So I think the first thing I want to know is what medications they've been on before. What have they had success with before? Why are they on UPA? Was it because they failed every single thing under the sun and it's their only option, or is it the first medicine they were ever on? And I think those are really different things. If they tell me that they're interested in becoming pregnant and we have other options for medical therapy, then we'll transition them. And I would like to watch them for 6 months to a year in an ideal situation, right? To make sure that they stay in remission. If that's not an option, then we have further discussions about it. But if you want the ideal scenario, it's flipping them, it's monitoring them, and then it's watching them for a little bit more of an extended period of time to make sure that they're still in deep remission. If you don't have that option or you don't have that opportunity, you switch and they conceive, and then you just monitor them very, very closely throughout with fecal calprotectins, with intestinal ultrasound, MRI if you need to, scoping if you need to as well. But it really depends on the prior scenario of their disease too.
Great. Thank you. I just want to say thank you again to our speakers. Let's give them a round of applause. And before we go to lunch, you have to listen to me read a list of our sponsors. So we want to thank again our platinum sponsor, Madrigal Pharmaceuticals, our gold sponsors, AbbVie and Ipsen, silver, 3D Matrix, Gilead, Dawn Forest, Gilead Ann Chung, and then Merck. And then our bronze, we have AbbVie, Amgen, Ardelyx, Castle, Cook Endoscopy, Ecosins, Eaton Pharmaceuticals, Fujifilm, Genentech, HepQuant, Johnson & Johnson, Keenova, Medtronic, Mirum, Nestle for Voust, Nestle for Zenpep, Orphalan, Avesco, Salix, and Steris. So thank you. We will have our lunch break. And then, Christy, what time are we coming back? At 12:15, we're going to start again. So thank you all.